Good afternoon. We are coming to you live from the University of the Philippines, Manila for the Lourdes Manahan Lectures in Rheumatology. This is the fourth installment of a four-part webinar series occurring every 2 weeks. I am Dr. Micheal Tee, a professor of medicine from the Division of Rheumatology, University of the Philippines, Manila, College of Medicine. Housekeeping rules for our participants. As participants, you are all muted. If you have any question or reaction, you can type them in the Q&A box and we will address them during the open forum. You will receive a certificate of participation to this webinar after you fill up and submit the evaluation form and post-test. You will receive it through email a few days to a week after the webinar. The link will be posted at the Q&A box and at the chat box prior to the end of the webinar. The Lourdes Manahan Lectures in Rheumatology is an annual event hosted by our division in honor of Dr. Lourdes Manahan, the first Filipino rheumatologist. Dr. Manahan pioneered the field of rheumatology in the Philippines in the 1950s. After postgraduate training in the United States, she returned to the UP College of Medicine to teach and serve the patients with rheumatic diseases consulting at the PGH. This is the 17th LMLR and Dr. Manahan's 100th birth anniversary. To give her welcome remarks is our special guest, Dr. Charlotte Chong, Professor and Dean of the UP College of Medicine.
Faculty for the 17th Dr. Lourdes Manahan Lectures in Rheumatology, and the participants who decided to invest their time to update their knowledge on basic science and clinical skills pertinent to rheumatology. This conference is in honor of the illustrious and grand lady of Philippine rheumatology, who is also the author of the Rotor-Manahan-Florentine syndrome when she was just a first-year resident, while Dr. Florentine himself was just an intern. This comes on the 100th birth anniversary of Dr. Lourdes Manahan. We celebrate by looking at the past with none other than national scientist Dr. Ernesto Domingo as the lead, but also revisiting chikungunya arthritis by Dr. Krista Rubio, her grandniece. This virtual conference is especially significant on the heels of a raging pandemic, COVID-19, showing that the dedication of our faculty to carrying on with the responsibility of advancing knowledge and sharing through these conferences like this. The example by which she has educated the present crop of rheumatology experts and saw all the patients in the rheumatology clinic by herself will be difficult to match, and her contributions to the vision and mission of the UP College of Medicine, tripartite missions of service, education, and research will forever be a source of inspiration and her life worth of emulation by all of us. Thank you to the organizers and staff who made this happen. Congratulations to Dr. John Anuevo, the department chair, Section Chief Dr. Evelyn Salido, and the dedicated faculty of the section led by Professor Emeritus Clemente Amante, Dr. Eric Amante, Dr. Paulo Lorenzo, Dr. Esther Penserga, Dr. Hazel Bernadette Manapat Reyes, Dr. Angeline Therese Santiago, Vice Chancellor Dr. Micheal Tee, and Dr. Geraldine Zamora. We salute you for carrying on the excellent tradition set by our beloved professor. Finally, let me express the fact that the college is really looking forward to the final publication of your book on rheumatology. Have a good day.
Thank you, Dean Chong, for your message, and we are much honored that you can join us today. I would also like to thank our sponsor, Novartis Pharma. And again, I'd like to welcome all of you, our participants. We have 105 now. This week's webinar focuses on the facets of management of psoriatic arthritis. Our speaker is Dr. Jose Paulo Lorenzo. Like Dr. Manahan, Dr. Lorenzo had his rheumatology training in the United States. He is a clinical associate professor of the UP College of Medicine and is past president of the Philippine Rheumatology Association. He is presently a member of the Asia Pacific League of Associations for Rheumatology's Executive Board. Let us now listen to Dr. Lorenzo's lecture entitled Addressing Real-Life Concerns in Psoriatic Arthritis. Dr. Lorenzo, sir?
Headed by Professor Evelyn Salido, the consultants, and the fellows of the division, for inviting me here today to give the fourth and final talk of the 17th edition of the Dr. Lourdes A. Manahan Lectures in Rheumatology. I have nothing to disclose. The outline of this talk is to review psoriatic arthritis and psoriasis, patient concerns, doctor concerns, patient-doctor alignments, and I end with a summary. Psoriasis is a chronic, progressive, heterogeneous inflammatory disease involving the innate and acquired immune pathways, which affects the skin, the musculoskeletal system, and other organs. It has a strong genetic basis. Psoriasis affects 2% of the world's population. Its prevalence varies, with 5 to 10% of Russians and Norwegians affected, and it's almost non-existent in West Africans and Native Americans. In the UPPGH dermatology clinic, 2.4% of their patients annually have psoriasis. Psoriatic arthritis develops in 10 to 40% of psoriasis patients. The age of onset frequently peaks in the 20s. The Group for Research and Assessment of Psoriasis and Psoriatic Arthritis, also known as GRAPPA, decided to define domains of psoriasis for the reason that they wanted to formulate treatment guidelines for each domain. So the domains are the skin, the nails, dactylitis, which is swelling of a finger or toe digit, enthesitis, axial arthritis, and peripheral arthritis. Here is a graph or a pie graph of the prevalence of disease domain manifestations in patients with psoriatic arthritis. The majority of patients presented with multiple disease domains reflecting the heterogeneity of disease presentation. And how you look at this pie diagram is the color blue represents the percent of this, I think these are 2,600 patients who presented with only one domain, and that's about a quarter of the population studied, while the majority presented with 2, 3, or more domains. Thus, the comment that multiple disease domains are common in psoriatic patients. Pathways. Just to give you a brief review of the cytokine network in psoriasis. This is the skin actually. You have your dendritic cells, your monocytes, your CD4 and CD8 cells of the Th17, Th22, and Th1 varieties. And these produce certain cytokines such as IL-12, TNF-alpha, IL-23, interferon gamma, IL-17, IL-22, and others. And all of these drive the inflammatory response. If you look at other tissues other than the skin, such as the bone marrow and the gut, they also produce inflammatory cells, which produce your cytokines. And for example, for the bone, you have an increase in osteoclast progenitors, increase in your Th1 response, increase in your type 17 response. And in the gut, you have your microbial dysbiosis, which has gained a a lot of interest in the recent decade. And it is believed that in psoriasis, there is an increase in IL-23 from the change in the microbial biome. And what these do is, if we look at first the top part of the right side of the slide, that's the foot, and we look at the enthesis, which is the insertion of your ligaments and tendons to bone. If there is biomechanical stress or trauma, in the presence of increased IL-23, this stimulates your type 17 response, and this produces your IL-22 and your TNF, which results in inflammation in the enthesis. There's also pathologic bone formation, wherein you have osteoprogenitor cells, which release your IL-22 and other factors, which stimulate your and activate your osteoblasts, which form new bone. And in the joint, you have your dendritic cells and your macrophages, which produce IL-23 and TNF, which in turn activate your lymphocytes and your synoviocytes to produce IL-17, TNF alpha, rank ligand, and this activate your osteoclast progenitors. In the presence of rank ligand, they become active osteoclasts, and they also, and as such, they produce bone resorption. For the joint manifestations, and this is from Moll and Wright, a long time ago, I think this is from 1970s. The different manifestations of psoriatic arthritis are asymmetric mono or oligoarthritis, symmetric polyarthritis, much like rheumatoid arthritis, distal interphalangeal joint involvement, your axial spondylitis and sacroiliitis, and your arthritis mutilans. And as mentioned, you have enthesitis and also dactylitis as manifestations of psoriatic arthritis and the other musculoskeletal components. So with that background, we now move on to the real-life concerns of patients with psoriatic arthritis. So when I was setting up this talk, I thought of what would concern patients most, and without really reviewing the literature yet, I said it would most likely be their quality of life, whether it be physical, social, and emotional aspects, and the resources that they have to depend on to deal with their disease, support groups, family, community, and public health. This talk will just focus on the quality of life issues. So this is a graph of the different domains of concern of health concerns of the psoriasis patients. So there were actually 12 patients who were asked, what 16 domains are important to you? And they listed them, and then 139 patients were asked to prioritize these different health concerns. And first and foremost was pain, then followed by skin problems, fatigue, ability to work, functional capacity, feeling of discomfort. So these first concerns were usually physical. And then we go to the psychological and emotional concerns, sleep disturbances, anxiety, fear and uncertainty, coping, embarrassment, shame due to appearance of their skin and joints, social participation, depression, relationships, concentration difficulties, rejection, discrimination due to their appearance, and sexual life. So obviously, there are a lot of the psychosocial concerns that are also important to the psoriatic patient. The burden of psoriasis versus psoriatic arthritis on the quality of life. So now we're comparing these the two domains. Compared to patients with psoriasis and psoriatic arthritis, there is a greater disability as measured by the HAQ score in patients with psoriatic arthritis. There is a lower SF36 physical component summary score in psoriatic arthritis. There is a lower European quality of life 5-dimension score. And there's a higher degree of fatigue score in patients with psoriatic arthritis over psoriasis. Differences in disability and physical quality of life are most likely due to functional disability caused by joint disease. And if you look at this other line, at least 1/3 of patients, of psoriasis patients, experience pathological worry and anxiety. So you might want to consider when the patient is waiting in your clinics to use an app or which are out there. And this is just an app by the Psoriasis and Psoriatic Arthritis group, which assesses the patient's HAQ score, pain visual analog scale, and global visual analog scale. And this can be done in the waiting room. I actually downloaded this app, and it's free and very easy to download. And you can use this so that before you see the patient, he or she has done some updating of how they're faring. And then you or your nurse can do your joint counts, the enthesitis count, and the skin assessment, and see how they are responding to whatever treatment you are giving them. We have to be aware that there are comorbidities of psoriasis, which increase the patient's disability, decrease quality of life, and decrease life expectancy. And these are hypertension, cardiovascular disease, which our patient had, obesity, metabolic syndrome, and there are other concerns, osteoporosis, depression and anxiety, malignancies, steatosis, dyslipidemia, and gastrointestinal disorders, and uveitis. Euler strongly recommends patient education as an integral part of patient care and should be tailored and needs-based. Educational resources are available to aid clinicians, such as written information, self-management programs, and resources to aid the sharing of experiences between patients. And so this is just a pamphlet of patient education for psoriasis. So very much available. And the whole point here is with patient education, compliance, and understanding their disease better will make their idea of where their disease activity is at more aligned with what the clinician or the doctor or rheumatologist thinks. What about the real-life concerns of the doctor? Diagnosis, treatment, pharmacologic and non-pharmacologic, patient education also, and the multidisciplinary approach is needed in the treatment of psoriatic arthritis. So the rheumatologist is the main man in the treatment of psoriatic arthritis. You involve the dermatologist, the physical and rehab medicine, general practitioners, and also the advocacy groups. Early diagnosis is the goal for all psoriasis domains. It's hard to diagnose, particularly in the early stages of the disease. And there's a delayed diagnosis with the usual lag time of 7 to 10 years from the onset of psoriasis. Hopefully, with all the information that we are giving, the diagnosis of psoriatic arthritis and the different domains will happen much earlier than 7 to 12 years. So what's the point here is that if it's never diagnosed, once they get arthritis, you already begin to have joint damage and deformed joints, and later on you have disability and severe pain, and you also, as mentioned, have your comorbid conditions that you have to deal with. This is a diagnostic tool that you can have in your clinics, and I think this would be most appropriate to be, aside from the general practitioners clinics, in the dermatology clinics. So the questions are: have you ever had a swollen joint or joints? Has a doctor ever told you that you have arthritis? Do your fingernails or toenails have holes or pits? Have you had pain in your heel? Have you ever had a finger or toe that was completely swollen and painful for no apparent reason? And in the drawing, you're asked to please tick the joints that have caused you discomfort, stiff, swollen, or painful joints. And if you even answer one to any of these questions, then you might be a person, if you have psoriasis, with already a psoriatic arthritis or its other domains. But who are the high-risk patients for psoriatic arthritis? Those with nail disease, those with psoriasis of the scalp or inverse psoriasis in the folds of your body, those who are obese, those who have a first-degree relative, and those, if you have the luxury of having a Doppler ultrasound and there are inflammatory changes in your Achilles tendon, then these are patients who most likely already have psoriatic arthritis. And I think this was already published by Dr. Scher in 2019. And to help you with the diagnosis, there's a classification criteria for psoriatic arthritis, or the Casper classification criteria. And it says a patient must have inflammatory articular disease, joint, spine, or enthesis, and more than or equal to 3 points from the following categories: current psoriasis or a family history, psoriatic nail dystrophy on current examination, negative rheumatoid factor, dactylitis current or on history as recorded by a rheumatologist, and radiographic evidence of juxtaarticular new bone formation. It carries with it a sensitivity of 91% and a specificity quite high of 98.7%. So aligning the goals of treatment. In the minds of the patients, they want to be able to continue with daily activities. And this is of critical importance and must be a key consideration for physicians when setting goals of treatment. Physicians, on the other hand, commonly focus on targeting inflammation and preventing joint damage with drug therapy, with the goal to maintain function and normal daily activities. So what are the treatment goals in psoriatic disease? And this I got from a lecture of Dr. Van der Bosch in the recently concluded APLER 2020. And he already is thinking of the patient and what the patient thinks or feels, wherein the main goal is maximal health-related quality of life, normal function, and social participation. So this is patient-centric. Through treatment which is effective on signs and symptoms of arthritis, enthesitis, dactylitis, sacroiliitis, and spondylitis, control of extraarticular manifestations, control of comorbidities, prevention of structural damage, and all, if possible, without complications. This is the Psoriatic Arthritis Treatment Toolbox, courtesy of Dr. Mees, which I got in 2018. So we have your NSAIDs, traditional oral DMARDs, methotrexate, leflunomide, sulfasalazine, and cyclosporine. We don't recommend azathioprine or hydroxychloroquine. And then we have your TNF-alpha or your TNF-alpha inhibitors, etanercept, adalimumab, infliximab, certolizumab, and golimumab. We have all of this locally except certolizumab. And note the adjunctive treatment, joint injections, PT, OT, exercise, weight loss. We know a little about obesity, dietary changes, acupuncture, omega-3 fatty acids, patient education, social support, and talk therapy. And we have new therapies, relatively new. Your IL-12/23 inhibitor, ustekinumab, Prevalence, which we don't have here, phosphodiesterase 4 inhibitor, secukinumab, IL-17 antagonist, ixekizumab, which we don't have, tofacitinib, we have, which is a JAK-STAT inhibitor, abatacept, we don't have. And in the development, there's new JAK-STATs, bimekizumab, I'm not sure if it's still being studied, gazelkumab, which has been released, risankizumab, and tildrakizumab. So early intervention, much like early diagnosis, is important. So the preclinical phase of psoriasis is what we should really target at treating. So when they're diagnosed with psoriasis, we realize that in about 7 to 10 years, they already might develop psoriatic arthritis. So do your risk factor assessment as shown in a couple of slides back. And if there's some degree of inflammation, you can already start treatment. Don't wait for symptomatic psoriatic arthritis to develop, because as you can see, once this happens, the joint damage also progresses. And usually when you're finally diagnosed with psoriatic arthritis, there are a lot of issues already with your joints, healthcare costs go up, and comorbidities also are taking place. So in 2015, there were two groups that came up with their recommendations for psoriatic arthritis, the EULAR 2015 and the GRAPPA 2015. The EULAR had their endpoint of treat to target endpoint of remission of the disease, or if not possible, low disease activity. And the GRAPPA group, they just decide their recommendations based on the different domains and how they should be treated. I shall just focus on the GRAPPA. So these are all the domains on the pink boxes on top. And if we just look at the peripheral arthritis treatment guideline, NSAIDs and intraarticular steroids are indicated in all phases of this disease. They recommend conventional DMARDs such as methotrexate, sulfasalazine, and leflunomide. And also first line are your TNF inhibitors and your phosphodiesterase 4/1 inhibitors. If these are not effective, or they do not cause improvement in the disease activity of the patient, you can try other biologic DMARDs, TNF inhibitors, IL-12/23, IL-17 inhibitors, and phosphodiesterase 4. If that doesn't work, you switch to another biologic, TNF, IL-12/23, and IL-17. And when choosing therapy, you consider previous therapies which the patient has gone through, the patient's choice, other disease involvement, and comorbidities. And the choice of therapy should address as many domains as possible. So Down the line, axial disease, enthesitis, dactylitis, skin and nails have their own treatment recommendations and guidelines. I just wanted to show to you how effective actually these medications are with regard to the quality of life of the patient. So this is Akitimab, IL-17 inhibitor. And you can see compared to placebo, which are the gray squares, whatever dose, whether it was the 300 or 100 milligram dose, you can see that the health assessment disability index, HADPI, improved significantly over a 2-year period. And the short form 36 health assessment quality of life also improved significantly from baseline compared to placebo. Pain improved and your fatigue scores also improved significantly. I wanted to talk about methotrexate and etanercept as monotherapy or in combination, because really, realistically, we have primarily methotrexate as an option for treatment, and the cost is really much more palatable for many people. So just to show you that methotrexate monotherapy is effective for treatment of psoriatic arthritis, for ACR 20, ACR 50, and ACR 70, although not as much as etanercept. The other thing that you can get from this slide is that combination of etanercept and methotrexate is the same as etanercept monotherapy only. So you might not need to give combination if you're going to give etanercept, and that methotrexate still works. So moving on, we looked at physician-patient discrepancies in the perception of immune-mediated inflammatory disease, psoriatic arthritis, and psoriasis. And in 2011, Dowden said that there was no significant difference between how patients and physicians considered their relationship. And they considered the relationship good or very good. A year before, 2010, the Hake mentioned that patients required more information about psoriasis, fast-acting treatments, clear expectations, and recognition of emotional burden, while physicians consider that patients do not internalize information adequately and need more information about treatment. For treatment, the discrepancy was 18.4%, and for 2016, for 2011, there was no significant discrepancy on treatment satisfaction and treatment compliance between physician and patients were observed. And in 2016, this is interesting, improvement in plaques on the limbs were more important than plaques on the torso for the physicians, but the patients didn't think so. They thought that improvement of the plaques on their torso was more important. And patients perceived a significant benefit in reducing mild plaque area from 10 to 0%, but physicians really didn't pay much attention to this mild improvement. So we are in the time of the pandemic, and it would be remiss of me not to even mention it. So what about psoriatic arthritis during this pandemic? There was only one article that we came upon by Wolina, and it was just mentioned that there are significant comorbidities that are risk factors for a more severe course of COVID-19, which we mentioned, hypertension, diabetes, and cardiovascular disease, also in the psoriatic patient. And we add here obesity. So in case they get COVID and they have these risk factors, then they might have a more severe course. They asked the question, does systemic medical treatment of psoriatic arthritis increase the risk for COVID-19 mortality? And the way they looked into this question was mortality of COVID-19 has been related to the development of pulmonary fibrosis. So should drugs which prevent fibrosis be preferred over others? For example, IL-17, phosphodiesterase 4, and JAK-STAT phosphorylation have been shown to have a role in fibrosis. So should the antagonists of these be used or preferred? There was no answer to this question. So care for patients with rheumatic diseases during COVID-19 pandemic, a position statement from ACLAR. So this is the first edition, and I got this. Despite the lack of data on the true prevalence and risk of COVID-19 in rheumatic disease patients, immunosuppressed status was not reported to be a risk factor and risk for adverse outcome. For now, patients with stable rheumatic diseases and psoriatic arthritis is included should continue their treatment. In case of infection, treatment of infection gains precedence and immunosuppressive treatment may be de-escalated or temporarily withheld in consultation with a treating rheumatologist. So in summary, patient real-life concerns are quality of life issues, physical aspects such as pain, disabilities, fatigue, psychosocial issues such as stress, anxiety, depression, and social interaction. Discrepancies exist between physician and patient impressions of their disease activity and treatment. Patient education is a tool for both patient and doctor to more clearly communicate specific concerns and expectations. Doctor real-life concerns. Physicians commonly focus on targeting inflammation and preventing joint damage with drug therapy, with the goal to maintain function and normal daily activities. Identifying preclinical high-risk patients may alter disease and improve outcomes. Treating comorbid conditions is mandatory. Conventional DMARDs are still recommended, and effective biologic drug treatment options have grown over the years. IL-17, TNF, IL-12/23, and IL. Thank you very much for your kind attention.
Thank you, Dr. Lorenzo, for your lecture. We have some questions in the Q&A box, and I'd like to encourage our participants to also add to the questions that we may clarify some things. And among the first questions, sir, would be from a professor of medicine. Question is there an ethnic risk for multiple domain involvement?
Thank you very much, Dr. T, and thank you for the question. As mentioned, the highest prevalence of arthritis is usually in Northern European population. So if that's an indication of whether they have more domains or not in that population, I would expect it so. Of course, genes plays a role here. There are definitely genes that are linked to skin disease or to musculoskeletal involvement, and these are the HLA-B and the HLA-C genes. So whether you have more domains or not, depending on your ethnic origins, it's not really answered, but I just will hazard a guess that if you're from a population with a high prevalence of psoriasis, then you most likely will have more domains of this disease. Thank you.
Thank you, sir. Another question is about obesity and psoriasis. Is there a correlation between obesity and psoriasis? And if so, how do we explain this correlation, sir?
Yeah. First of all, a lot of patients who are uh, with psoriasis are obese, and it basically when you're obese, your fat tissues are actually drivers of inflammation in and store certain inflammatory proteins which drive inflammation. So what I really wanted to emphasize about obesity is that when you lose weight significantly, your activity of psoriasis and joint pains markedly improves among all aspects of the domains. So uh, obviously there's a correlation with inflammation and obesity. Now, whether these are the leptins that we read about, it's possible. Thank you.
Thank you, sir. That's also something similar with our patients with osteoarthritis. Patients with osteoarthritis who have high levels of adipokine also experience hand swelling more, more severe than those who are not obese. Another question, sir, is about when do you shift or what do you do for patients who have methotrexate inadequate responders or methotrexate intolerant? First, the question would be among those who are methotrexate intolerant. Some patients, as many rheumatologists would attest to, start feeling nauseated one day or the night before they take methotrexate. So, what's your strategy for these kinds of patients?
Yes. First of all, I methotrexate is really for me the ideal drug for our setting because of its available and of course the cost. The cost is very much affordable in our setting. Okay, so when the patients experience nausea or vomiting before or after they take oral methotrexate, you might want to consider doing another route of administration. And this can be intramuscular through the intramuscular route. Um, and see if that works. You might also want to just give them some medication for the expected nausea, whether it's metoclopramide or some similar drug, and see if that works. Now, if they really cannot tolerate methotrexate, whether it's whatever route you give, then I already will consider offering them the biological DMARD treatment and discuss with them what options we have available. Uh, Now, there was, I think, a question on the dose. If you notice the only article that I cited for methotrexate with comparing it with the etanercept, the dose of methotrexate that was actually being used was 20 milligrams a week, which I think for many of us is on the high side. But I think this should be our target dose in case the patients do not respond at a lower dose. Now, what is my starting dose? I would still start with a 7.5 or 10 milligram dose of methotrexate, see if they tolerate it, see if how they respond to it, maybe in about 2 to 3 months, and then we can push and bring up the dose even to about 20 milligrams per week. But of course, we have to monitor very closely their liver function tests. Thank you.
I hope that also answers the questions of Dr. Kea Bravo. Let's go back to the multi-domain cases. There's a question here. Is there a particular domain that needs more immediate attention than others when it comes to initiation of treatment? And is there really a difference in treatment when you talk about multiple domains?
No, definitely. There are some domains which cause more disability. That's one. So right away, it's the joint. If you have to be more aggressive with treating the joint musculoskeletal domain. Now, the other domains, such as the skin and the nails, definitely they also cause a lot of physical discomfort to the patient. But more than that, they also cause a lot of psychological and emotional issues with the patient. Um, if the patient has musculoskeletal, spine involvement, much like ankylosing spondylitis. This is also an indication for you to be very aggressive with treatment. I'd like to emphasize here that treatment should be done as early as possible, even before you even uh, suspect that the patient might already be having musculoskeletal manifestations. You're already thinking that you have to start treatment right away, and this will give us a head start in preventing further damage to the musculoskeletal system. Thank you.
Yeah, one thing that is commonly seen in our practice is the use of steroid. Many patients will come to our clinic already taking this magic drug of steroid given by neighbors, friends. Can you comment on the oral intake of steroids and also whether there is a benefit to using topical steroid among our patients?
Okay, so if you remember the slide on the toolbox of the different uh, treatments for psoriasis and psoriatic arthritis, steroids definitely has a role in controlling certain symptoms and signs of the disease. Intraarticular steroids we give, um, topical steroids for the dermatologists they give, systemic or oral or intravenous steroids are given. However, we don't really encourage it because of the very known phenomenon of a rebound flare when you eventually discontinue giving the steroid. So as much as possible, if there's really no choice but to give a systemic steroids, they should be given for a very short period and tapered rapidly. And in the process, you also have to think of your other disease-modifying anti-rheumatic drugs that you can give so that you don't need to depend on steroids for the chronic treatment of this disease.
Yeah.
Thank you.
We have from our Q&A panel a question on the surgical management of psoriatic arthritis. When do we decide to refer a patient for surgery and what are the usual reasons for these referrals?
Well, thank you for the question. Surgery is really dependent on the patient's disability, if you ask me. So if, for example, the patient is already having so much difficulty walking because of very far advanced knee psoriatic arthritis, in spite of whatever treatment is available, medical treatment is available, then I would consider actually surgery, possibly knee replacement or joint replacement in these patients. But if we get them early enough and treat them very aggressively, hopefully we will not reach that point where they need surgery. Definitely, surgery has a role in far advanced disease and where disability and activities of daily living are much affected.
You mentioned, sir, about, thank you, sir, for that answer. Uh, you mentioned something about this pandemic and how it affects our patients. There is a question from Alexia Pai Maglangit about mental health. Do you think that the pandemic is affecting our patients' mental health at this time? And if so, how are you managing them?
Yes, thank you for the question. Well, to start with, if you have psoriasis, you're already, as you can see in the first few slides, you're at risk of developing some mental health issues, depression, anxiety, and feeling like you're isolated, whether it's because of your skin, your nails, or your joints. So the question is, during this pandemic, do you think that this is going to be aggravated? I don't have any data, so this is just my opinion that definitely, if you're in a certain degree of anxiety and stress, and you're told that because of your psoriasis, your immune system might be compromised, and therefore you cannot uh, leave your house or visit your doctor, then definitely it must affect the psoriasis patients. How am I dealing with them? Uh, uh, Clinically, in my practice, I do a lot of, as you must also be doing, teleconsults, and basically they are doing quite well actually. It's they just consult to inquire whether they need to resume or maintain their medications. I do get an occasional frantic call because of a flare and what to do. But with regard to mental health, I don't know. I'm just guessing that they probably have a lot more anxiety and a lot more stress. Thank you.
On that note, sir, we can also mention that our section had a study on the psychological state and associated factor of patients with lupus and rheumatoid arthritis. And we found that pandemic affected 20% of our patients having moderate to severe impact of events, and that about 20% had moderate to severe depression, stress, and anxiety. And anxiety went to as high as 38.7 among patients with lupus and RA. So you can just imagine the kind of impact this pandemic had on already stressed, depressed, and anxious psoriatic arthritis patients.
Yeah.
This paper was co-authored by Dr. Micheal Tee, Dr. Salido, and Dr. Reyes.
Yeah.
So
Thank you for that
another question.
information,
Yes.
Dr. T. Um, Stress, I just like to mention that stress is really one of the triggers of psoriasis. So I would be very interested to see if a lot of the psoriatic patients of yours, if you have them, are having flares of their disease during this pandemic.
Yeah.
Thank you.
Thank you, sir. Now, maybe we're down to the last two questions. What is the best time to use methotrexate, and is it true that prolonged use can cause cataract problem after 40 years, or maybe after 40 years old?
Okay, so when is the best time to use? Since it's our first line of treatment, once you've made the diagnosis of psoriatic arthritis, or as I'm emphasizing, even before clinical evidence, clinical appearance of the disease, maybe they show inflamed enthesis or elevated inflammatory markers. That's the time you should start a methotrexate treatment. So don't hold back. Be very aggressive with treatment. And with regard to cataract, after 40 years old, I don't have any information about that. I know that definitely with corticosteroids, but with methotrexate, it hasn't really been an issue. It's more of your liver. You have to constantly monitor your liver, and if if you've been on methotrexate for many years, cumulative dose, there is a risk of actually having some form of liver damage.
And maybe our last question is, in the advent of oral small molecules in patients afraid of injection of biologics, do you prescribe oral JAK inhibitors for psoriatic arthritis? And in what particular domain affected would you choose that?
Yes, so for the small molecules, the JAK-STAT inhibitors, it's already recommended in the treatment of all the domains of psoriasis, including psoriatic arthritis. So this is definitely an option that you can offer your patient. Um, and what was the follow-up question, Mike? Sorry.
What domain? What domain of
What domain?
these
So I would use it.
concern?
I would use it in any domain because it's already shown to be effective for the domains of psoriasis. Thank
So
you.
I think that's it. We covered a lot of concerns, and I'd like to thank Dr. Lorenzo for answering those questions. I'm sure our audience learned a lot from you today. And I'd like to thank the audience for your questions, which help clarify